I'm Dr. Rajneesh Kapoor. So we know we are heading towards a scenario where we are following a concept of leaving nothing behind in the coronaries and still treating the coronary lesions.
There'll always be an inherent risk of restenosis with stents because it's metal within, it's a foreign body within the vessel. That in itself is a problem, plus when you factor in the endothelial dysfunction, the problem with vasomotor function, there's going to be always a risk of restenosis that I don't think we'll ever be able to remove entirely. So that opens up an opportunity for something else.
Right.
Leave nothing behind.
Once we have stented, the side branch is pinched. Again, the DCB is a very good option.
Personally, I believe in paclitaxel.
Right.
Okay, I think that offers more advantages than a limus-based approach.
India is a capital of diabetic world. I mean, diabetes is biggest in India. I mean, the incidence is huge.
Yeah.
So, and what you are saying, small vessels is absolutely extensive in India, I would say.
Yeah.
2.5, 2.25, we get fairly commonly, practice in cath lab. We see that very frequently.
It's just becoming more predictable, better outcomes, safer. You don't lose any sleep when you send a patient home now.
I agree. So that's what we are heading towards. Hey, hi. Good morning to all of the audience. I am Dr. Rajneesh Kapoor, Chairman Interventional Cardiology at Medanta Medicity, and this is a special podcast. And in this podcast, we'll focus on a very fascinating evolution in the field of cardiology, which are drug-eluting balloons. So we know we are heading towards a scenario where we are following a concept of leaving nothing behind in the coronaries and still treating the coronary lesions. So to talk on this, we have a special guest today with us, Dr. Simon Wilson, who has traveled all the way from UK.
It was my pleasure.
Yeah. So he's a consultant at St. George's University Hospitals, London. And he has a vast experience with cardiology, the field of cardiology, with procedures, drug-eluting balloons, and all the complex coronary interventions. Welcome, Dr. Simon.
My pleasure. Thanks for inviting me.
Great to have you. So this is it, and we'll be discussing on various other topics also besides drug-eluting balloons, like calcified lesions, intravascular lithotripsy, and more innovative stuff which is happening and which is coming with intravascular lithotripsy in the times to come in India too. So Dr. Simon, may I ask you, what is your strategy with these drug-eluting balloons? What is the pragmatic approach, I would say, where you think that these are the subsets where drug-eluting balloons is going to be very productive for cardiac patients?
There's no doubt in my mind that drug-coated balloons have got a role. Stents are fantastic. We're lucky to be in an era where we are with stent technology. But there'll always be an inherent risk of restenosis with stents because it's metal within, it's a foreign body within the vessel. That in itself is a problem, plus when you factor in the endothelial dysfunction, the problem with vasomotor function, there's going to be always a risk of restenosis that I don't think we'll ever be able to remove entirely. So that opens up an opportunity for something else.
Right.
Leave nothing behind.
Right.
So conceptually it makes sense to me. In terms of my practice, I think there's enough evidence, and I don't think it's particularly controversial to say that DCBs are at least non-inferior and perhaps even superior to DES in small vessels.
Right.
Where you draw the line, do you say a small vessel is 2.25, 2.5, 2.75? Personally, I feel sort of 3 millimeters or less I'd be comfortable to classify that as a small vessel, and I'd be looking to use a DCB as my first line.
Okay.
What about you?
So so I think at the moment we are still sticking to the indications of ISRs.
Agree.
Where we prepare the bed well and go with the DCB. We don't want a second layer of metal caging the vessels further. And mind it, India is a capital of diabetic world. I mean, diabetes is biggest in India. I mean, the incidence is huge.
Yeah.
So, and what you are saying, small vessels is absolutely extensive in India, I would say.
Yeah.
2.5, 2.25 we get fairly commonly, practice in cath lab. We see that very frequently. So I think that makes sense in a diabetic diffuse disease in coronaries to use DEBs.
Oh, for sure. I was, an interesting thing, the US guidelines though, if you had ISR in the US, they still say that a second DES within a failed DES is the first line strategy. Now, I could disagree with that. What do you think?
I also think. I think there is no point caging it further, and all the vasomotor function is gone with repeated caging. So I think we should give it a chance to a patient where we just do a cutting balloon, prepare the bed well of the ISR, and do the DCB inside the stent.
I agree. Optimize any stent problems. If it's under expanded, fix that. Treat any in-stent problems, often with a cutting balloon, and then DCB.
So I think fairly, I would say our practice is that we keep it a balanced approach. In proximal LADs, in left mains, obviously we are still doing stenting in all such lesions, but a smaller mid to distal vessels, small caliber vessels, ISRs, and the side branches across, once we have stented, the side branches pinched, again the DCB is a very good option. And in younger patients coming to us with acute myocardial infarctions, with less of atherosclerosis, with more of a thrombotic burden, I think we clear the thrombus and do the DCB and come out, leaving nothing behind.
I agree. I'm very similar. Every small vessel, I want to go try an upfront DCB approach. Every side branch, even if it's osteal left circumflex, try to simplify things. We know that 2-stent strategies are fun to do, but not necessarily the best for the patient. All ISR and some large vessels, and that's where I think it becomes a bit more controversial depending on how you interpret the evidence. I would certainly say that, there's always mission creep, isn't there? You do DCB in some small vessels, then you do moderate vessels, and then you start to think, I'll do it in large vessels. Then along comes rec cage free, and we think, clearly in that trial, DCB was shown to be not non-inferior to stents. Right. So then we reset ourselves a bit, and then solution de novo comes along. We think that's an all-comer trial, including large vessels. That shows that actually a DCB with a solution device seems to be non-inferior to death, so people start to use it again in large vessels. Then we get the news last week that if you analyse the trial per protocol, which is appropriate for a non-inferior trial, it might actually not be non-inferior. So what do you think about doing it in large vessels? Is there any situations where you would do it in a large vessel?
That's what I'm mentioning. If it is a young patient, compliant soft vessels, no calcified lesions, and also one more thing I like to add. Since we are doing a lot of imaging now, we prepare the bed, look at the imaging before putting a stent or before deciding with a stent versus DCB. If the imaging shows that we are getting a good MSA, good area within the vessel, we haven't stented, so no MSA, but good area and no bigger dissections, and the coronary is maintaining a good TME3 flow, I think we do the DCB and come out.
Yeah, I couldn't agree more. I think that, all the current sort of guidelines say these are the criteria to DCB. Angiographically less than 30%,
yes,
good flow, and then there's a line about FFR. But I think if we're going to move DCBs on where they can be equivalent in more situations, i.e. larger vessels, we need to use imaging.
Yeah.
The reason why I think we don't necessarily need to use imaging in smaller vessels is stents do really bad in small vessels, so the bar is quite low.
Absolutely.
In large vessels, stents do extremely well, so therefore we need to up our game. And I absolutely agree. I use imaging in every DCB case, and I have my own little mental checkbox.
Right.
Less than 50% residual stenosis, no large hematoma, which you can only see on imaging,
Absolutely.
no big medial dissection, TME3 flow, I'll DCB, walk away, and I'll be confident that patient does well.
I tell you a few scenarios to handle the very complex diffuse disease vessels which we get in Indian subsets. So we have prepared the bed well. We were all prepared for doing the DCB to the whole segment. And after preparing the bed well, we have done a imaging. OCT or IVUS, whatever we use, more OCT. So after doing the OCT, we felt that there is a small 10 millimeter area in the vessel which is very bad. Which has a very bad dissection. So we have only fixed that 10 millimeter with a stent and rest with the DCB. So it's a blended approach.
Oh yeah, the hybrid approach. There's no RCT for that hybrid approach, but there's prospective trials that show that MACE events are very low, and then some observational data that says that hybrid approach may be superior. And to me, it's attractive. But I would say to the people that are, are less familiar, that when you do a hybrid approach, you still need to observe the rules about DES implantation. You need to have a good landing zone. You can't just whack it into loads of disease and think it'll be okay.
So this is where the imaging is a big boon.
Yeah, for sure.
So my next point of discussion is, do you think all DCBs are same?
That's a good question, isn't it? One of the important things, there's a big divide between whether paclitaxel or limus, and depending on which mechanistic study you look at, you can make an argument for either. Personally, I believe in paclitaxel. Okay, I think that offers more advantages than a limus-based approach. So, number one, is that paclitaxel-based device? It would be important to me. Second thing is, what about how much of the drug is present on after the transit all the way through? So that's another important thing. If it all comes off, then it's going to be useless. There's important things about how the drug, once the balloon's inflated, gets into the vessel wall. There's lots to consider. The Prodigy in itself is a product that I've been using for the last 18 months, done over 100 cases. I think its unique selling points are: one, paclitaxel; two, it's very, very deliverable. It's once the balloon's folded, it's then crimped and corrugated, and whatever that does, all I can tell you is, I don't know if your experience is the same, it's much more deliverable than older devices. And then it's got this interesting thing where you can deploy it 3 times. And when when you look at that, you look at the third inflation and think, well, it's way down, but it's actually still above the minimal inhibitory concentration to maximally inhibit smooth muscle cells. So there's something in that. I like it because it's deliverable, and there's nothing worse than when you open the packet, you've made that investment, or the patient has, and it doesn't go down the vessel. That's frustrating.
I absolutely agree with this. So one thing, the message is very clear for everybody. DCB, 80% is the preparation of the bed, and 20% is the drug deliverability, which should be delivered. And that is our objective, to deliver the drug there, because that is the one thing which is going to retard the endothelial hypertrophy which happens with restenosis. So we are trying to retard the process of restenosis by delivering a drug there. So it has to be delivered, but preparation should be very good. So you prepare the bed well with non-compliant balloons or cutting balloons, whichever technology you are comfortable with, do that, and then use the DCB to deliver the drug.
Oh, for sure. Somebody summarized it quite well a few days ago. If you do a stent-based approach, the stent does a lot of the heavy lifting, If you do a DCB approach, the vessel preparation does a lot of the work.
Absolutely. Absolutely.
So that is key for sure. You get some people that are DCB zealots, and they promote this messaging that we can simplify PCI. You put a semi-compliant balloon in, you blow it up. If it angiographically looks a bit better, and we can convince ourselves of anything visually, then you DCB and it'll all magically remodel. If our aim is to alleviate angina, which is the predominant benefit in elective patients, we have to get luminal gain.
Absolutely. Absolutely. So if we don't do this properly, and we are suboptimal here, the patient is going to come back with restenosis, and then that whole cycle continues. So this is a good discussion around DCB. Another thing, let's move slightly further. So in India, we get lot of diabetic calcified vessels. I don't know about UK, that
Scotland.
Scotland. Scotland. I think there are still many calcified coronaries which you see there, because the expectant life expectancy is much higher there. So maybe in older people you get lot of more calcified vessels.
That's true. There's a lot of calcium. I think there's a lot of calcium in every lab around the world.
Yeah.
Either if your population is genetically predisposed and they'll come younger, or because people are living later and we're offering PCI to 70-year-olds, 80-year-olds and beyond. So calcium is just the major problem in the cath lab.
Right. So once there is a calcium, we know that it's a villain in coronaries, and the stents do not expand well. We do not get good MSAs until we have used a very good calcium modification device. So we are very comfortable using this IVL. There are other devices also. We use Rota, we use orbital atherectomies, but IVL is quite operator friendly and it gives us very good results.
Yeah.
So I think to prepare the bed well in coronary calcified lesions, what's your take here, that how frequently we should use these devices to decalcify the arteries and then stent it?
I mean, definitely IVL came along and filled the big gap. There was a huge requirement for, wasn't it? So it's it's here to stay, and it's just fantastic for us and our patients because it gives us a good option in a large number of scenarios. It's extremely safe. It's not to say that IVL you need to use it in every calcified case.
Right. Right.
I don't know what your approach is, but there's occasionally in a case with your experience you'll realize that calcium is so thick, so hostile, I'll need to go with an upfront device.
Yeah.
But many times when you see it, I would probe with a non-compliant.
Cutting balloons.
No, I usually go with a non-compliant, adequately sized, taken to 16-18 atmospheres, not beyond that, and then that informs me of the pattern of compliance. If it's fully expanded, I'm ready to go.
Yeah.
I'm certainly ready to stent. Might not be ready to DCB, but if there's wasting of the balloon, then I can infer from that: is it concentric? Is it dog boning? Is it focal eccentric, or is it diffuse eccentric? And then after that, you can make your decision.
Right. And also imaging helps here. So
Yes.
we get to know whether it's a nodular calcium,
Yes.
what is the depth of calcium, what is the arc of calcium. So if imaging tells us that it's a very extensive, vast calcium, we can pick and choose this choice that you go with the non-compliant balloons, scoring balloons. There is a trial by Ajay Kirtane from US which tells that if appropriately used, these non-compliant balloons may be at par with using the calcium modification devices.
I think a lot of the trials, almost all the trials, the randomized controlled trials in calcium are angiographic criteria, angiographically severe, and ergo the majority of these patients have concentric calcium. So
Right.
these are trials of concentric calcium.
Right.
And concentric calcium is very forgiving for the mechanistic shortcomings of all balloon-based devices.
Agreed.
Which are really, you can classify them as pressure-mediated, compliance-dependent. So their performance is absolutely determined by the pattern of compliance. If there's concentric non-compliance or circumferential target, that's fine because the force applied will be orientated to the target.
Yes.
But when it's eccentric non-compliance, if you just apply more and more pressure, obviously what's going to happen is balloon's going to expand away.
Yeah, it's going to expand in the opposite direction.
Absolutely.
And that's where the complications start.
Definitely.
So I agree. Concentric calcification, we can create fractures with non-compliant balloons, but if nodular or very deep calcium protruding into the lumen, that is where we require more of IVL.
Definitely.
And upfront we can pick and choose after the imaging. We can try it out to fracture with non-compliant balloons, but keep it as an option that if we need to use IVL balloons, do not shy away. So use the IVL balloons, create a lot of fractures, and we have seen extensively that after we have done imaging prior to IVL, we have done imaging after IVL. So it creates a good number of fractures, and that is where we get a better MSAs post stenting in such lesions. So IVL usage, I think now, previously IVL balloons were available with 80 pulses, and now we have extensive more pulses added to that, 120 pulses, IVL balloon which we have been using for years. So that is something very productive once we have more pulses and we create more fractures, and especially if the length of calcium is big, we require more pulses.
Oh, for sure. I'll just make one other comment as well. I think in concentric calcium, nobody can definitively tell you you're doing the wrong thing. Trial evidence wouldn't really support. Although I would say that Shortcut was actually a trial in favour of IVL. Although some people would say, look, it proves that cutting balloons were non-inferior to IVL. But actually, the devil's always in the detail. With that trial, unless you used atherectomy up front, then the cutting balloon wasn't non-inferior to
Absolutely.
IVL. Anyway, I think in concentric calcium, it's almost dealer's choice. In eccentric and nodular calcium, to me, it makes no sense to apply more and more pressure.
Right.
The only thing that's predictable at that point is the risk of perforation.
Right.
So to me, it's a toss-up between atherectomy, if you think you need to debulk, and then IVL.
Right.
And the thing I was going to ask you, what I was going to go into, is that all these algorithms have always taught us to make our decisions based on the morphology. But what about safety?
Right. So yes, so we need to have our own guidelines with our experience, and obviously if the nodular calcium and we keep on inflating, we are heading towards, we are exposing the patient more towards perforations. So debulk the calcium with these devices and then go ahead with stenting. So that should be the strategy in such patients.
Yeah.
Debulk it appropriately. So now one thing more, in specifically if we talk of India, we now are getting many IVL balloons, but now there are more IVLs being added. So do you think all IVLs will be absolutely at the same level and they will be performing at the same level, or there may be a difference? We don't know still.
Yeah. So is there a class effect? I think once you understand how the safety and performance of a shockwave is defined, then I think you'll agree probably not. It's dependent on the profile of the waveform. The maximum amplitude, the length of the positive phase, the negative tensile phase, which is the hazardous phase. It depends on the emitter location, the emitter firing sequence. There's so much that goes into it. All I can say is that Shockwave has spent many years modifying the waveform to achieve its maximum effectiveness with maximal safety, and that there's so much. I love the detail. I just love the detail about this. There's so much they've done about the electrode firing sequence, positioning, etc., so that you've got a consistent sonic output circumferentially and longitudinally.
Right.
So we can say Shockwave IVL have done this, and unless somebody has engineered a device that is identical, then I think it would be folly to assume equivalence in performance and safety. So I don't think there'll be a class effect.
I think only time would tell, but at the moment we know that the time-tested Shockwave IVL, which we have been using for years, is very effective, and performance of other IVLs will be tested with the course of time. Matchability or not matchability, there are other aspects also, whether the balloon gets perforated at what pressures, how formidable is the balloon lining,
and how deliverable, if you can't get it into the zone.
So this is also very important, whether that balloon is deliverable to the site of calcium or not, and then whether it perforates, whether it ruptures at some point earlier as compared to the previous Shockwave IVL. So that needs to be seen with time. So this is one. I think most dependable remains, which is time tested.
Yeah, definitely.
So that's one aspect. And now if we move to the second aspect, do you think that even IVL modifications are in the pipeline that is going to make it more productive, more performance friendly, and less complications? I know that Shockwave IVL is coming with few modifications. One is Javelin, of course, that will be with us probably somewhere late this year or next year. So have you used Javelin?
Yeah, we were lucky enough to be part of the Javelin, the sort of initial trial to see whether there was a safety and effectiveness, and then part of forward IDE. And so Javelin is exciting. It's a device for wire crossable device uncrossable, where typically you then have to swap out for a rotor wire, which makes some people nervous, and then rotably.
I think so. To tell you, the name javelin is really good because javelin is something which is thrown forward.
Yes.
So javelin shock wave will be a shock wave which is throwing the shock waves in a forward direction. Where the catheter hasn't reached, the shock waves will reach.
Yes.
So this is absolutely, as Simon has put it, that it is for a non-crossable calcified lesions where wire has crossed but nothing else is crossing.
So it's a microcatheter that's 014 compatible, so you don't need to change your wire. The emitter is located close to the nose. You push the microcatheter into the lesion and then you deliver 10 pulses, just maintaining a modest amount of forward pressure, and it slowly makes its way through the lesion. Now when we first started using it, I thought this was a device that just allows us to cross, and then we'll have to do a lot more calcium modification afterwards. But actually it's not the case.
Right.
Once you've crossed, it's one and done generally.
Oh.
It disrupts the calcium sufficiently that afterwards all you need is a non-compliant balloon generally, check compliance, and then stent. Incredible.
So for the audience who is not knowing about javelin is not a balloon. It's a microcatheter with the emitter at the tip of the microcatheter, and that's a fluid-based tip. So some fluid-based thing is there which is emitting shock waves in a forward direction.
That's exactly right. So it's got a trying to think of a device that's similar, but you have to flush the port.
Absolutely.
So you have a second system on it where you deliver 10 pulses, and then as we know, when we deliver pulses, it sometimes creates little air bubbles. So then you flush the nose with some saline to wash out any bubbles, and then you give another 10 pulses. It's incredibly easy to use.
I think it may be a huge innovative device in the field of interventional cardiology that will make very complex non-crossable lesions very easy to handle, perhaps.
Sure.
Need to be seen with time.
Oh, definitely.
Okay, so this is a good discussion about DCBs and calcified lesions and usage of IVL.
Well, we got the Aero device.
Aero device, yeah. So Aero device also is coming in the pipeline with the shockwave IVL, which is probably making it more deliverable.
Oh, for sure.
Yeah.
And we don't have it in the UK yet. I think it's coming to India sometime this year. It's the next iteration of the coronary IVL balloon. So we had C2, C2 Plus, and now it will be Aero.
Aero device.
It's the same length, but it's just been iterated so it's much more deliverable. It's much more rewrappable. And the slight change is that the emitter locations have been moved forward.
Right.
So colleagues in the US that are using it a lot say it's incredibly deliverable.
Right.
It wraps a lot better, and I think that is a big deal, because if you have a circumflex that's calcified, it's annoying if you can't get it across. If you then have to reach for another device or you have to open a guide extension, that's time and money.
Right.
If you get this version of the device means that we can avoid all that, then I think that's a good step forward.
Absolutely. So I think with these innovative things happening in the shockwave balloon therapy, it's going to be much better dealing with the calcified lesions, decalcifying it in a more efficient manner, and then getting better MSAs. So I think it's going to be very, very handy and productive for patients.
It's making it too easy for us now.
Oh, I think yeah. So surgery is almost getting obsolete with this.
I know.
So I think we are waiting for these newer devices to be with us, and we start using. Probably end of this year or next year we'll have all these new devices, and with these we know that if we compare PCIs being done a decade back or now, there is a huge change.
Oh yeah.
In terms of outcomes getting better, in terms of complications going down, and now we are not afraid discharging a patient very next day after a complex PCI.
Oh, definitely.
Yeah. So what is your protocol? When do you discharge the patient after no complication PCI?
An elective patient, they go home the same day.
Same day.
The only caveat would be if we've done them late on the list. And there's a thing in the UK where they have to generally stay after any PCI for 4 to 6 hours. observation based on historic evidence that if there was a vessel closure, it tended to happen within that time
Within
period.
that 6 hours period.
Yeah, so they have to stay for 4 to 6 hours. But if that means that they can go home at 8 p.m, then they'll just go home. So the majority of elective patients go home, and then for end-STEMI patients, inpatients, they generally go home the following day.
Right. So
What about you? The same?
So we keep the patient one night.
In elective as well?
In elective as well. So since we are a very high volume center, and many of the patients are done from the groin, and then they require some pressure there, although we're using angioseals and proglides very frequently, but still as a protocol we're keeping it for one night, and next morning we release the patient.
If you moved more to radial, and I know that you do more femoral because smaller population, smaller radial, but if you did more radial, would you send them home?
Yeah, no hematomas, no vascular complications, and we send the patient.
But it goes back to your point before. If we use imaging and we've got IVL to help us and we've got DCB to treat the smaller vessels, it's just becoming more predictable, better outcomes, safer. You don't lose any sleep when you send a patient home now.
I agree. So that's what we are heading towards in our practice also.